Nathan Ritter coming at you with Clinical Vascular Ultrasound Interpretation for Cardiologists. Lecture 1, some basic concepts and vocabulary. So getting oriented, the principles of image creation are the same as echocardiography. The transducer is usually linear, so it's straight, and uses higher frequency than cardiac ultrasound because the vessels they're looking at are usually right under the skin. They're superficial structures, unlike the heart, which is deep within the chest. This is an example of a 5 to 12 megahertz Phillips probe. So an exception to this is abdominal studies where they use a curb probe with a lower frequency because the structures are deep. Some terminology in vascular ultrasound world, B mode, you'll see that on tests, means just grayscale imaging or 2D imaging like we do in echo. Spectral Doppler, this is an important one, just means pulse wave Doppler. And then color Doppler is the same as color cardiac Doppler. So here's an ultrasound image, and the B mode portion is the grayscale image, and then the color Doppler portion is here, just like an echo, and this down here, this down here is the spectral Doppler, this portion. So power Doppler, here is a form of color Doppler that shows magnitude but no direction of flow, and this can be used to differentiate total occlusion in a vessel from subtotal occlusion. We in our lab almost never use it, but if it's just a almost totally occluded internal carotid, the tech will use the color Doppler, the power Doppler, to try to show some trickle flow. So this is about image orientation. When you're looking at the image, how you can visualize where the patient is. And images are basically always oriented as if the head were on the left. So in a carotid study like this one, flow is going from right to left towards the guy's head. And then in this example here, in the abdominal aorta, flow is left to right. So the flow is actually happening this way in this vessel here. It's going that way, because the guy's head's over here. So it helps you visualize which way the flow is. This is an important difference between vascular ultrasound and echocardiography, because unlike in echocardiography, in vascular ultrasound, the displayed spectral waveform, this guy, is upright in the expected normal direction of arterial flow. So I'm sure that sounds like a lot of blah, 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 but you actually have to understand this. So I'll keep going. In an echo, for example, with aortic valve flow, the Doppler tracing shows the velocities in the downward direction below baseline. Because in echo world, down equals away from the probe, which equals negative. So this is negative here, minus 1 meter per second. But in arterial vascular ultrasound, down doesn't mean away from the probe, down means in the wrong direction, flowing in a direction it's not supposed to. So it's a completely different way of showing the velocities. And if you don't understand that, you'll get mixed up when you're looking at studies like I did for a couple of months, because nobody really explained it to me. In the course I took it online, they just kind of assumed everybody knew it. So let's do this example. This is a vertebral artery, so the head is to the left over here. And this little artery, the flow is supposed to be going towards the guy's head. But actually, the flow is this way. So the sonographer knows this and flips the waveform and depicts it below baseline. And so since the flow is away from the probe too, because the probe's up here and you can see this is the trajectory of the ultrasound waves like that. So the flow is actually away from the probe. So in echo land that would be depicted as negative. But anyway, in vascular land it's also depicted as negative because it's in the wrong direction. And then because it's away from the probe, it's negative over here on the scale. Minus. But wait, there's more. So let's do another example. Down, here it's down, it's below the baseline. It means wrong direction arterial flow. This is another vertebral artery. Head is over here, feet. So flow is supposed to be towards the head, but flow is actually in this direction. And the ultrasound probe is this way. This is the way the waves are coming. So the flow is has a vector towards the probe, which in echo land would normally be positive. And it's also positive in vascular land, but because it's in the wrong direction, it's flipped. I'm sure this is agony to hear me talk about this still, but if you pay attention to this, then the tracings will make sense. If you don't, then you'll be confused. So over here on the scale, it's positive because it's towards the flow, towards the probe. And like this confused me because in echo land, this is not supposed to be like this, so that's what mixed me up. Another difference between echo and vascular. Unlike in echocardiography, you can't get the beam close to parallel to flow. So generally, they use a 60-degree angle of incination, and this angle is pretty obtuse, so that means they have to correct for it. And we don't correct for angles of incination in echo land. So the sonographer indicates the direction of flow in the vessel with an arrow, and that's this thing right here. The sonographer puts that there. And then the machine calculates the angle between the direction of incination and the direction of flow. Then the machine uses this angle to adjust the magnitude of the spectral Doppler velocities. So they take the measured angle and divide by the cosine of the angle, a little trig, and then this is what the machine depicts. So if the sonographer chooses the wrong direction, if they choose the wrong direction, then the displayed velocity will be wrong. Again, if the arrow is in the wrong direction, right here, that arrow, this guy, then the displayed velocity will be wrong. And the error could be substantial, and this is a topic that would be tested on the boards. The RPVI exam, I guess, what they call it. So vessel tortuosity, twisty vessels, curvy vessels, make it hard to get the right direction. So flow in this vessel here was marked like this, but maybe it was more like this over here. Maybe it was more like that at that point. That's a big difference in angle. And so in this example, if the correct angle is more like 30 degrees, not 60, you're looking at a substantial difference. The cosine of 30 degrees is 0.87, cosine of 60 is 0.5, so that's a big difference. And in this case, the displayed velocity, displayed peak velocity was 136 centimeters per second, but the correct peak velocity was 79 meters per second. So over here. That's what's displayed, but the correct velocity would be more like this. That's a common source of error. I don't know, I pay attention to that more probably than most people do, but it'll be tested on the RPVI exam. Okay, changing topics, we're going to talk about spectral Doppler. And you'll hear this a lot, spectral waveform analysis. That means looking at these pulse wave traces and thinking about their shape, which is more important in vascular land, probably than it is in echo land. I guess it's important in both. So there are two groups of shapes. They're the high resistance shapes and the low resistance shapes. The high resistance shapes are these are tracings that are seen in vessels that go to high resistance vascular beds. This is a normal tracing would look like this. Triphasic flow. Triphasic. And it goes 1, 2, 3. So the flow is forwards and then backwards a little bit, then rebounds and goes forwards. And that's thought of as a normal flow pattern. Mildly abnormal flow pattern would be biphasic flow, forwards, backwards a little bit, never goes forwards again. In my experience, this is super non-specific, but anyway, that's mildly abnormal. And then the dreaded monophasic flow just goes up slowly. And this is significantly abnormal, and it's like a parvis et tardis waveform, like you might see in somebody with severe aortic stenosis, and you did a pulse volume recording in a peripheral artery. Actually, like this. So this pattern, this high resistance shape, is expected in low flow arteries to inactive muscle, like your muscles. They're not doing anything, so all the arterioles are small, so the resistance is high because the muscle doesn't want any blood, so it rejects it. It makes all of its little arterial supply arteries small, and then the blood gets sent elsewhere, like your brain, during this lecture. I hope, anyway. There are other inactive intestines. So your intestines aren't doing anything. There's nothing going through them. You wouldn't want a bunch of blood flow to them. All the arterioles are small. Some examples would be the subclavian artery, which goes to your arm. The external carotid artery goes to the face. It's muscles, after all. It's not your brain. And the superior mesenteric artery in the fasting state. These would all have triphasic flow. This pattern can be present abnormally if there's a severe downstream distal stenosis or in the arteries of dead kidneys. So, for example, your right renal artery tracing in a patient with like a totally dead right kidney. While there's high resistance, it's going to look like this. High resistance, it's going to be probably look like this one. Up, down, nothing. And again, that's downstream from the stenosis. So it's like there's not a lot of flow because it's blocked downstream. So onto this side, the low resistance shapes. Low resistance shapes looks like this. Kind of, it would sound like because the flow is constant. Right, there is constant flow. It varies throughout the cardiac cycle, but it's present throughout the entirety of the cardiac cycle. As opposed to the triphasic flow over here, which would sound like. Anyway, this is expected in high flow arteries to the brain, kidneys, active intestines, dialysis fistulas, very active muscle. And it's present abnormally in pathological AV fistula. So that makes sense. You guys all know what it sounds like when somebody has a AV fistula and you auscultate them. It sounds like so that's the pattern in an AV fistula. Some examples to demonstrate the patterns of flow. This would be a normal high resistance pattern in a right subclavian artery. And this is the tracing here, and it's pretty much triphasic. Up and down, and then a little bit of up there. There's the expected sharp upstroke, and then the reversal of flow due to elastic recall of normal arteries, and then a reflected wave, boing, due to normal elasticity of the vessel. Triphasic. Pretty much a biphasic, mildly abnormal high resistance pattern in a left subclavian. We'll zoom in here, and it goes up, and it goes down, and then it doesn't really go. It doesn't go back up over the baseline here. It just goes. Well, there it did a little bit. Shoot. Up here over on this side. So this is a biphasic pattern and super non-specific, and I don't really pay attention to that too much clinically, to be honest. There's a loss of the reflected wave due to stiff vessels. And another one, this is the monophasic one. Super important because in vascular land, you oftentimes do not see high velocities. Like in echo land, we're generally looking at the velocities and the DVI across the aortic valve. But in vascular land, sometimes all you see is a monophasic pattern with lowish velocities. And that's the indicator that there's a major stenosis upstream of the place you're interrogating. So this is the parvus et tardus concept. Kind of goes up slowly. It's kind of curvy. It's not as sharp of an upstroke. Very super abnormal. So in this is the right subclavian. In subclavian, when they interrogate that, the person's face is actually right in front of you. So it's like you're looking at their face. And this would be the left one over here. Anyway, the fact that this is really monophasic, low velocity, tells you that there's a blockage down here somewhere. You can't see it. The probe can't interrogate that deeply, but there's a narrowing. So there's poor flow through here, and that's why it measures poor here. And you can't measure the velocity here. This would be a high velocity, but they can't see it. Anyway, we're done there. Some more examples. This is a normal low resistance pattern in a vertebral artery. The brain is sucking blood out of the aorta constantly, uses so much energy, and so it has flow constantly throughout the cardiac cycle. There's forward flow throughout diastole as well. Anyway, so systole, forward, and then diastole. Whoosh, 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 whoosh. That's normal. Here's a low resistance pattern in a left subclavian artery because the arterial supply of the arm is going to an AV fistula. So there's a lot of flow through that, that artery, and that's going to be whoosh, whoosh, whoosh. And this is a low high resistance pattern, this one. It's not straight low because of this. But anyway, that's what an AV fistula flow looks like. It's usually not a mystery. You know they've got it to start with. This is important. It's a high resistance pattern in a low resistance artery, the vertebral artery. It heads over here, flow is this way, and it's supposed to be, but it is not. It is just, and that indicates a severe downstream stenosis. So it's a high resistance pattern, meaning that the vertebral artery is blocked up here where it can't be seen. New topic, description of plaque. This is one of the great things about vascular ultrasound. I love it. You really get to see the enemy in a way you don't in echo land. See the atherosclerosis. Yeah, see it live. It's even better than CT. So we'll go to the terminology over here. Plaque composition. What's it made of? Is it gunk or is it calcified gunk? And so soft, the terminology is soft equals non-calcified equals echolucent. Hard, calcified, echodense, mixed, heterogeneous, calcified, non-calcified. You get it. This part's more interesting. So the plaque surface, this is the fun part over here. Soft and smooth. This one here is mixed, hard, and soft. See a little crunchy part there. Over here, this is a dense rock-like plaque, hard plaque. And then this is where it starts to get nasty. This one is kind of, I said it's irregular, but honestly it's kind of ulcerated. Irregular would be just if it was bumpy. I don't know, can't, because it's red, I can't really show that. If it's bumpy and nooks and crannies. But this is ulcerated. There's a part that's lifted up. So, ulcerated. My editor has work to do. Last thing. Quantification of stenosis. So it's the part you're waiting for, probably. We'll start with quantitative parameters. Peak systolic velocity, which would be here on the tracing, and end diastolic velocity. That's not something we use in echo-land, so that's something new. The end diastolic velocity is a parameter. And then this is a familiar parameter, the ratio of the peak systolic velocity at the stenosis compared to the peak systolic velocity in the non-disease segment. Paroxysmal stenosis, this is just like aortic stenosis, where you're using the peak velocity at the stenosis, which is like the velocity, and comparing it to the velocity, peak systolic velocity right before the stenotic area, which is just like the LVOT tracing. But they invert the ratio compared to the DVI. We use the slow one over the fast one, so it's a decimal, but a fraction of one. But in vascular land, honestly, it makes more sense. They use the inverse of that. So 4-to-1 would be a very high ratio. So let's see. This is an example here of doing the calculation. This is in the right ICA. So over here. And the main number that you're looking at when you read the test is just like, boop, look at this number over here. 184 centimeters per second is the peak systolic velocity. And we've got to do a ratio. So we look at the distal common carotid, That's the segment that's proximal to the right internal carotid. I know it's a little different from the internal carotid because there's the external carotid comes off of the distal common carotid, but anyway, blah, blah, blah. When it's a right ICA stenosis, proximal segment, you're going to use the distal common carotid velocity. Here it is. It's 74. So the ratio over here is 184 over 75 equals 2.5 to 1. So that's the ratio. That's how you calculate that. So let's do, there's also qualitative parameters. There's the monophasic waveform. That's a qualitative parameter that indicates severe stenosis proximal to the area of interrogation, and that was the same example I showed you earlier, the severe proximal right subclavian artery stenosis. There's this qualitative parameter of the monophasic waveform. Low velocity, there's no sharp upstroke. It doesn't look like that. It does not look like this. It's just a little mound, parvus et tardus. There's a stenosis proximal, because it flows this way. Proximally, there's a stenosis. They can't see the high velocity, just the waveform. Another qualitative parameter, this one's nonspecific. It's called spectral broadening, and you'll see this on the RPVA exam. This over here, this is a new concept. I haven't touched on it yet in the lecture. This shows laminar flow. Laminar flow is normal. There's no spectral broadening, meaning it's just a line and like this. This one over here is abnormal. It shows spectral broadening, which just means that the whole thing is filled in. And it's the difference in appearance between, pulse wave is usually supposed to look like this in echo. And so spectral broadening is when your pulse wave looks like a CW. Again, it's not a CW. It just means that there's multiple velocities in this location, a whole bunch of them, because it's turbulent flow. And then, fudge. There we go. Lastly, there's the appearance of the plaque. And the appearance of plaque is, you don't really look at it and grade it and say, oh, look at that plaque. It's covering 50% of the vessel lumen. Nope. Doesn't work that way where you're looking at it and grading it. It's just the appearance of plaque is used to differentiate mild disease from no disease. That's what the appearance of plaque is used for. Unlike angiography, you can't estimate the percentage stenosis from plaque appearance. All right, so that's the end of the first lecture.